Snapping triceps syndrome is a rare but often misdiagnosed orthopedic condition where a portion of the triceps muscle dislocates over the medial epicondyle of the humerus during elbow flexion. Patients may feel or hear a snap, sometimes with pain, especially when bending the elbow. This syndrome can coexist with ulnar nerve instability, leading to additional symptoms like numbness or tingling. Despite being first described in 1970, awareness remains low, and many cases are overlooked or mistaken for other elbow problems. Understanding this condition is crucial for proper diagnosis and treatment, as it can significantly impact daily activities and athletic performance. Napping triceps syndrome is most commonly seen in adolescents and young adults, particularly males, with a male-to-female ratio of nearly 4:1. The age range of affected individuals is broad, from children as young as 9 to adults up to 65, but the majority are between 15 and 40 years old. Many patients are athletes or laborers, with activities like weightlifting, wrestling, or repetitive manual work increasing the risk. Previous elbow trauma, such as childhood fractures, can also predispose individuals to this condition. Despite these trends, the true incidence is likely underreported due to frequent misdiagnosis. Mechanism behind snapping triceps syndrome involves the triceps muscle, which is made up of three heads that merge into a single tendon attaching to the elbow. As the elbow bends, the triceps broadens and can slip over the medial epicondyle, especially if certain anatomical or biomechanical factors are present. These include bone deformities like cubitus varus, soft tissue variations such as hypertrophy of the medial triceps, or even previous surgeries that alter the normal anatomy. The interplay of these factors changes the angle and pull of the triceps, making dislocation more likely during movement. Key concept in understanding snapping triceps syndrome is the triceps angle, or T-angle. This angle is formed by the line of pull of the triceps muscle and the line of the proximal ulna. Similar to the Q angle in the knee, changes in the T angle can increase the risk of the triceps snapping over the elbow. Factors like bone deformities or muscle hypertrophy can shift this angle, altering the direction of muscle force and making dislocation more likely. Recognizing and measuring the T-angle helps clinicians assess the risk and plan appropriate treatment. Several anatomical factors can predispose someone to snapping triceps syndrome. Osseous or bone-related factors include deformities like cubitus varus or hypoplasia of the medial epicondyle, which can shift the triceps line of pull. Soft tissue factors include hypertrophy of the medial triceps head, the presence of an extra fourth triceps head, or thickened fascial bands. Sometimes previous surgeries or injuries can also create conditions that favor snapping. Understanding these factors is essential for accurate diagnosis and effective treatment planning. Patients with snapping triceps syndrome usually report medial elbow pain, a snapping sensation, and sometimes numbness or tingling in the hand. These symptoms often worsen with activities that involve elbow flexion, such as push-ups, weightlifting, or manual labor. In many cases, the snapping is both palpable and audible, and some patients can even reproduce it on demand. The condition is frequently associated with instability of the ulnar nerve, which can lead to additional neurological symptoms. Recognizing this symptom pattern is key to identifying the syndrome early. Striking feature of snapping triceps syndrome is its frequent association with ulnar nerve instability. In fact, over 90% of patients in the reviewed studies had some degree of ulnar nerve involvement. This can manifest as tingling, numbness, or weakness in the hand, particularly affecting the ring and little fingers. Sometimes the ulnar nerve itself subluxates or dislocates during elbow movement, contributing to the snapping sensation. Proper assessment of the ulnar nerve is essential for both diagnosis and surgical planning. Diagnosis of snapping triceps syndrome relies on a combination of clinical examination and imaging. During the physical exam, doctors look for snapping or popping during elbow movement and check for ulnar nerve instability. Dynamic ultrasound is the preferred imaging method, as it allows real-time visualization of the triceps and ulnar nerve during movement. MRI can help identify anatomical variations or bone deformities, but it is less useful for capturing dynamic events. Accurate diagnosis is crucial, as many cases are only recognized after failed surgeries for ulnar nerve problems. Snapping triceps syndrome can be confused with other elbow conditions, such as isolated ulnar nerve dislocation, distal triceps rupture, or intra-articular pathologies like synovial plica. Distinguishing between these conditions is important because treatment strategies differ. For example, isolated ulnar nerve dislocation may not require the same surgical approach as combined triceps and nerve snapping. Careful clinical and imaging evaluation helps ensure the correct diagnosis and avoids unnecessary or ineffective procedures. Initial management of snapping triceps syndrome is usually conservative. This includes rest, avoiding activities that trigger symptoms, using nonsteroidal anti-inflammatory drugs NSAIDs, and physical therapy to modify movement patterns and strengthen surrounding muscles. Some patients may benefit from activity modification, such as avoiding deep elbow flexion or heavy lifting. Conservative treatment is often tried first, especially in mild cases, but if symptoms persist or worsen, surgical intervention may be necessary. Surgical treatment is considered when conservative measures fail or when symptoms are severe. The type of surgery depends on the underlying cause. If a bone deformity like cubitus varus is present, corrective osteotomy may be performed. For soft tissue abnormalities, procedures may include resection or centralization of the dislocating triceps segment, and sometimes interior transposition of the ulnar nerve. The goal is to eliminate snapping and restore normal elbow function. Surgery has a high success rate when the diagnosis is accurate and all contributing factors are addressed. Structured operative algorithm helps guide treatment decisions for snapping triceps syndrome. The process begins with a full evaluation to identify all contributing factors, including ulnar nerve involvement and anatomical abnormalities. Osseous issues are addressed first, followed by soft tissue corrections. For the triceps, resection is recommended if the dislocating segment is less than 1.5 cm wide, while centralization is preferred for larger segment. Intraoperative testing, including passive elbow motion and sometimes electrical stimulation, ensures that all snapping structures are resolved before closing the surgery. After surgery, postoperative care is crucial for optimal recovery. Protocols may include immobilizing the elbow in a flex position for a short period, followed by gradual reintroduction of movement and physical therapy. Pain management, wound care, and avoidance of high-stress activities are emphasized in the early weeks. Most patients regain full range of motion and can return to normal activities within a few months. Close follow-up ensures that symptoms do not recur and that healing progresses as expected. Prognosis for snapping triceps syndrome is excellent when properly diagnosed and treated. In the reviewed studies, nearly 98% of patients who underwent surgery experienced full resolution of symptoms. Recurrence is rare, especially when all contributing factors are addressed during the initial procedure. Most patients return to their previous level of activity, including sports and manual work. The key to success lies in meticulous evaluation, accurate diagnosis, and comprehensive treatment of both bone and soft tissue abnormalities. Snapping triceps syndrome, though rare, can cause significant discomfort and functional limitation if not recognized. Increased awareness among clinicians is essential to avoid misdiagnosis and unnecessary surgeries. Advances in imaging and surgical techniques have improved outcomes, but further research is needed to refine treatment protocols and understand long-term prognosis. For patients, early recognition and appropriate management can restore function and quality of life. As knowledge grows, so does the potential for even better care in the future.